the Low Carb MD podcast. I am here and I'm so excited. Our guest today is truly, in my opinion, a revolutionary, somebody who's been at the forefront of metabolic and mental health, and somebody whose own story really moved me when I had the chance to meet him in DC several months back. We have the pleasure of having Dr. Matt Bernstein here on the podcast. And I know I just talked with Brian. He's so upset he couldn't make it when he heard some of the story that you shared with me in DC, which I hope you share today. Just a quick background. Dr. Matt Bernstein is the Chief Medical Officer at Ellenhorn and Accord, and he's going to tell us about both of those. Two very important metabolic and psychiatric practices. He got his MD from UPenn. He did his residency training in psychiatry at Harvard, and he and I participate in really moving the needle on metabolic and mental health together on some committees, which, I think are really, really super important. And I'm so thankful. Guys, he's got a super busy schedule, but he moved some things around to make it today. So I just want to say how grateful I am to have him here, and honestly, how curious I am to hear more about his personal story and how he got to be at this point at the forefront of metabolic and mental health. So Dr. Bernstein, can we do Matt intro? Is that all right with you?
Absolutely. Yeah.
Okay.
Yeah. And
Thanks for
thanks for
coming on.
having me. Yeah, I really
Thanks for coming
appreciate
on.
being here. It's great to be with you and to be able to share this with your audience and interact. So thanks so much.
Well, look, we've talked about the forefront of metabolic psychiatry and metabolic health and metabolic psychiatry a little bit, but and maybe before we go into that further, maybe just we could step back and introduce who you are, how you came to psychiatry, and then maybe how you got to this growing field of metabolic psychiatry. I'd love to hear that. And if you're open to it, sharing some of that story that I
Sure.
got to hear back in DC, which was really moving for me.
Sure. Sure. Yeah. So, I'm obviously a middle-aged guy, been a psychiatrist for 25 years. But prior to that, I was a regular guy, grew up in Philly, went to school and studied English literature, and then decided to go into medicine, partly because I was interested in psychiatry. I knew I was interested in the stories, the connection with people, and I knew it was also just such a field where we didn't know that much science, so that I knew it was going to change a lot during the time of my career, and I thought that was exciting. That we didn't have it all figured out, or even close, and we still don't have it all figured out for sure. Um, so that's sort of what drew me into psychiatry. I had a couple of experiences as a young person too, where one of my best friends in high school, his older brother had schizophrenia and actually tragically died at a young age. He was very, very ill, and we sort of witnessed that and kind of went through that together. And it really was powerful to see how much that kind of brain condition can, mental health condition can upend someone's life. And when I went into psychiatry, I was definitely interested. I thought to myself, I'm going to work with the people with the real serious conditions, a real something that, it's not just something that talk therapy might help, but something people who need some biological, powerful intervention. Um, so I got trained at UPenn and Mass General and McLean. I was working on the inpatient psychotic disorders at McLean for about 8.5 years, uh, training residents um, and medical students, and really enjoyed the teaching part. Eventually left to go to Ellenhorn because it was a place that was really creative, and we would work with the same population, but after they left the hospital, and to try to get people reintegrated back into their lives. Really, we didn't, we're lucky in that we don't have a lot of restrictions in terms of how we work because of the way the company is set up. So we don't have a, JACO looking over our shoulder, and so we can really be creative. So we have clinicians going with people to class if they need to get to class but are too anxious or depressed to get there. We have clinicians making sure people can go to big family events when otherwise they would be excluded from the wedding or the funeral because of their mental health condition. So we really make sure people get integrated back into their life, and that's incredible work, great teamwork as well. Um, and then, sort of the next phase of the story is talking about my kids. So, I'm doing this work. My wife's actually a psychologist. She's got a, therapy practice. We got three boys, and this was about close to 9 years ago now. One of them, we have twins who were 14 at the time, and our youngest one was 12. And they went from being happy, well-adjusted kids who were, doing well in school and playing sports and had friends and playing music to literally overnight completely unable to function. Within weeks, they went from, straight A students to literally not being able to go to school and not being able to read. And it looked very psychiatric. Like they had anxiety, they had depression, and that's initially what we thought. Everyone thought, like, okay, they're having some kind of like mental health crisis. Where it came from, who knew? But, let's do the typical stuff. And we could access good treaters. We got them on medications. They literally got worse every time we put them on a medication. Not just that they didn't get improvement, but it would make them agitated and more suicidal. I mean, it was just we were like flailing here. I mean, we could not figure out what to do. Eventually, we sort of figured out that there was a lot of stuff that was going on that didn't look like straight mental health. And eventually they got this diagnosis of PANS, which is essentially autoimmune encephalitis. And it really, that sort of opened things up towards different types of treatments. Eventually we did get them seeing some, people who really understood how to treat that. And they did get a lot of improvement from very non-mainstream medical treatment. And
Can you talk a little bit about that? Because the listener, and you and I know,
yeah,
sort of a little bit about PANS and autoimmune encephalitis, and we know these things, right?
yeah,
But the average person out there, who may be seeing their kid who's maybe acting differently all of a sudden, may or may not have a seizure. Just walk me through, like,
right.
what it looked like. Because I mean, you guys, you're a doctor, your wife's a psychologist too.
Yeah.
I mean, and you're navigating this, but help me understand, like, what did it look and feel like?
Yeah. I mean, well, it looked and I mean, we were feeling completely helpless and, devastated and crazy. I mean, because we couldn't help our kids and the standard stuff that we knew wasn't helping them. When we finally figured out it was this, it was still scary because there weren't standardized treatments. There weren't treatments mostly that insurance would cover for this kind of thing. And essentially, what autoimmune encephalitis means, just for the listeners, is autoimmune means the immune system is attacking the body. The immune system does not recognize the difference between an invading bacteria and a regular cell, and it starts attacking the regular cells essentially, and the immune system starts causing inflammation, really runaway inflammation in the brain because it's attacking areas of the brain. And that's what was leading to these symptoms that they look like mental health, like I said, but they were there was a lot more. There was all these cognitive symptoms, and they had urinary symptoms, all kinds of things that were going on, which is pretty typical for that PANS picture. And one of my sons ended up with, pretty severe weakness and adrenal collapse, essentially. He needed, steroids, hydrocortisone to be able to function for years, actually. And then eventually, took years, but eventually he got off of it. Um, so yeah, the whole body's involved, and this is the thing that most important to take from all of this is, you know, the personal level for me, of course, and my wife and my kids, but from a overall big picture level, the brain is not separate from the body, and the field of psychiatry and mental health treats the brain as if it's completely separate from the body, right? And this is a huge problem. That really, I learned that lesson like pretty deeply during this period. That, like, wow, like we need to bring mental health back to being connected to what's going on in the rest of the body here.
It's so true. I think really it's underappreciated. Like B12, the effects of B12 on mental health, all the B vitamins,
Oh yeah,
right? Like carnitine deficiency, vitamin and nutrient deficiency. I
Yep.
mean, how intimately it's related, and conversely, the impacts of sugar additives and on mental health and mood. It's like, we dropped all of this for this neurotransmitter chemical story, which, not to say that it doesn't, like, I acknowledge the benefit of medications, right?
Yep.
It's rigorous trials have shown some of these agents can do it, but there's so much more. And how do you feel, where's the field gone? I've always felt like psychiatry was a very open field
Yeah.
because the science was always evolving. But this idea that, I have this saying, which is, you don't have a mental health disorder until medical issues have been ruled out, medical and
Right.
nutritional issues have been ruled out. And here's a case, and the case, your story fits that mantra so well.
Yeah.
I mean, your kids could have been diagnosed with a behavioral issue, right? Very easily, right? They could have been blamed on that, but there was a serious organic medical issue.
Right.
So, can you tell me, like, a little bit about, you know, has your experience changed the way you look at mental health? Can you tell me about your colleagues in the field, how they approach it?
Yeah.
How do they look at you? How do you look at them? Give me an idea of where metabolic psychiatry is and where conventional psychiatry is, and
Yeah.
how close are those, gaps?
Yeah. Yeah. Great questions. And just, you know, the reality is that my kids did get diagnosed with mental health, behavioral health by any mental health practitioner who saw them, would only see that, right? And some of them, when we started going down this other road of seeing it as more of a medical condition, were, pretty upset with us and saying like, look, you're going into a realm of non-science here. What are you doing? Um, and of course, we were lucky enough to be able to understand well enough to not listen to them and get our kids the help that they really needed. But I, was really thinking about all the times that regular mental health practitioners, psychiatrists, psychologists, social workers are saying like, look, the medical stuff's been ruled out. You had your CBC and your Chem 12 and your TSH. You don't have a medical problem. It's all psychiatric, right? And that's all that's been done, right? They haven't done any of the things that you described. And there's, a whole list of 50 other medical things that can cause, profound mental health presentations that really need to be thought about. Um, and we just don't do that in regular psychiatry, unfortunately. And I don't think the field has changed much. If you look at the research, you can see all kinds of amazing, deep and complex understandings of mental health conditions. But the way it all gets practiced clinically in the real world is, if you're lucky, you get a CBC, a Chem 12, and a TSH. Some outpatient psychiatrists might not even do that and just diagnose you with depression or OCD and just start treating you with a powerful medication, or I should say drug, really, not medication, that is going to alter your neurotransmitters, which is very powerful, and not really think about any other potential root cause of that condition.
I think the biggest area that really makes me a little concerned, right, is the fact that there's so much infectious disease
Yeah,
that can cause psychiatric disease,
that's right.
right? I mean, how many people are ruled out for neurocysticercosis or toxoplasmosis
Right.
or neurosyphilis or herpes encephalitis? Like, how many people are really ruled out for these things,
Yeah.
right? I mean, if you have a case, I saw a case very recently,
Yeah.
a 40-something-year-old patient with new onset, what appeared to be a psychotic break. And he's got two cats at home, brand new
Right.
cats.
Right.
Like, and nobody was like, should we image the brain? Like, the question didn't
Yeah.
even come up.
Right. Yeah.
Should we image the brain? He went back and forth to the ER, getting sent to the ER and sent back home on a new slew, different medications,
Yeah.
misdiagnosed as insomnia, misdiagnosed as anxiety. and then had a true psychotic episode. But nobody was like, well, maybe we should just look at the brain. Or
That's right.
maybe we should think about what are the potential etiologies here. So, I mean, how do you navigate all of this? I'm just curious, like, is there protocols to be thorough? Do these things need to be excluded? Should we not exclude them? I mean, how do you,
It,
you
it's really
know,
tough. I mean, yeah, I mean, someone who has a new psychotic episode should probably get imaging no matter what. They should get a brain MRI, not a CT, but an actual MRI. Um, you know, it's not, you know, we need to rule out these big things, and that will rule out some things. It doesn't rule out a lot of things, and it's most likely going to be negative, right?
yeah,
But that doesn't mean we shouldn't do it because you will catch some if you keep doing it. When I was an inpatient doctor, I used to get imaging on any first break person if they never had it. And we did catch a few things that were really interesting. We had new diagnoses of MS that no one had seen. So there are a few things that you can see, and you need to do a really much more thorough blood panel. All the nutritional deficiencies that you talked about. We need to think about infections. Even if you just think about COVID, how many people have long COVID? We know that the virus itself can persist in the body for years and years, and the spike protein can, right? So how much is that causing a problem for some people at this point? We're now, years after this new novel virus that we know causes, tremendous mental health issues for some people. And are we thinking about that still? I mean, when someone comes in with a new case of depression, that started a few years ago, are we thinking to ourselves, how much is, not clearing COVID part of that? So there's so many complicated potential causes. It can make your head spin, and you can't necessarily always rule out all of them. That's the part that's really daunting to clinicians. Um, but we need to be thinking about those things, and we need to be thinking about treatments that honor the fact that we may not know the cause.
I think I just want to go even further. There was just a huge study. I think it was out of Stanford that showed that there was a tight link between chronic EBV and
Yeah.
MS, right? Like, so this idea of long COVID, I don't know how to feel about it, but this idea of chronic infections, I
Yeah.
mean, it's definitely worthwhile. And the problem is how do you exactly detect it? How do you go to the tissue level and see what's going on? You really need to think and work empirically and rule out. Do you feel like your colleagues have the same sort of drive to rule out? Do you feel like there's walk me through, like, what does the guidelines say right now for like an acute psychosis out there? Brand new does it say get brain imaging on every acute case? Does it say check, for chronic infections or nutritional deficiencies, or like what are your colleagues doing?
Yeah, it's such a great question. I don't even know what the latest guidelines are. I've been involved in looking at guidelines, and they vary. So one group will come up with this, another group will come up with this. Some of them are very short rule out guidelines, some of them are a little bit longer. None of them are really all that thorough. But even more importantly, no matter what the guidelines say, it's just not happening.
Yeah,
People are not doing it.
yeah,
People are in practice, they're running a practice. They've seen people, let's say 15-minute visits. A new patient might get 45 minutes to an hour. That's just very typical, right? And psychiatrists are not in the position to order all these tests in an outpatient practice. They are often they're not adept at ordering lab work at all. It's just the
yeah,
reality. And doctors and a lot of psychiatrists will avoid prescribing certain medications that require regular blood work. I've seen this as a trend in the field. So, for example, lithium is a very useful medication in people with bipolarity. They have manic episodes and depressive episodes. Lithium can be incredibly useful. It is the gold standard medication for that condition. And
yeah,
yet, the trends have been that people are not prescribing lithium because it requires regular blood tests. And now we have these other medications that have been approved these atypical antipsychotics that don't require, regular, kidney tests and thyroid tests. And, they still do recommend, of course, if you're taking an atypical antipsychotic, that you should be getting your metabolic labs checked. But psychiatrists often aren't getting that done. They're pushing that off to the primary care doctor. And so it's just a lot simpler and easier in their practice, I think, to avoid doing all those tests. And so the reality is just these rule outs, these workups for medical causes are just not getting done, not very thoroughly. And individual people and families are sometimes gravitating towards uh, alternative practitioners who will do all those workups, a functional medicine doctor or an integrative medicine doctor or just a thorough primary care doctor who would do those things. Um, and that's a good thing that people can advocate for themselves. But I feel terribly for all the people who are out there just getting diagnosed with a major mental health condition. They didn't have a big medical rule out workup, and they just start getting put on very powerful antipsychotic, mood stabilizing medications, and then they end up often on, if especially for people with bipolar, the average amount of medications is five. They're on five
Wow.
medications on average. Their metabolic health is going to suffer tremendously from that, as we know. And then they're in a state of chronicity at that point where no one's expecting them to recover from this anymore. No one's expecting them to get back on the trajectory of their lives. And they're essentially lost into the diagnosis and mental health system. This is happening to millions and millions of people in our country right now. It's appalling, actually.
Yeah, I think we all deserve better, and there's such a huge crisis.
Yeah.
So can you walk me through maybe, so we understand what the problems with the current system, the occurrence-based psychiatric system, the lack of curiosity, lack of testing. Can you walk me through maybe sort of how your clinic has approached it, how you've, approached it? I was hearing a lot of innovative things when we talked in
Yeah.
DC.
Yeah.
So I'd love for you to just walk through the listener through, maybe where your clinic is and what the ideals that you're striving for are. What should metabolic care look like? What should metabolic psychiatry or psychiatry in general look like?
Yeah.
I'd love to hear your vision for the future because
Sure.
people need hope.
Yeah. Yeah. Well, I think even before I describe in detail what Accord does, which is, this metabolic uh, treatment, um, I think it's really important just to talk about the ketogenic diet and the brain a little bit and and the body, because what we're talking about here is sometimes even with a good workup, we may not find a smoking gun that we can reverse very easily. We can do the MRI, a huge set of lab work, um, and we may not find, what might be a root cause, but that doesn't mean that there's not something going on in the body that's causing all of this. We know that all these conditions are associated with brain insulin resistance for sure, mitochondrial dysfunction, brain inflammation, increased oxidative stress in the brain, something going on with the microbiome gut-brain axis. All of these are causes of these mental health conditions. No matter what started it, no matter what the infection or toxin or trauma or metabolic issue, genetic issue that may have started it, all of those things are common, right? And all of those things get better when we put people into ketosis. And so we have a treatment that not only, does all that for the brain, but also improves the functioning of the liver and its detoxification pathways, improves the functioning of the immune system, improves the microbiome, gut-brain axis. So, we have this treatment that's going to cover a lot of these bases. And we see it be incredibly powerful for all of these brain mental health conditions that have been working with for 25 years. It works well on all of them, which is so that's just, once I learned about that, it really opened up the possibility of, okay, we don't have to, always find the smoking gun. We can still help people no matter what the root cause was. We can look for smoking guns and do our best to treat as many of them as we can. But either way, once they're in ketosis, they're gonna start improving. And that's exactly what we see.
Yeah, I mean, I think being I'm curious what you think. Where does the benefit come from? Is it eating a diet that makes you nutritionally replete? Is it the anti-inflammatory effects? Is it through the microbiome? Is it just improving metabolic syndrome, improving the mitochondria? I mean, what do you think? How does diet affect the brain? So help
Yeah.
me understand how you view it and how you communicate that to your patients.
Yeah. Well, I mean, I would say yes, 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 and yes. I think all of those things are important. And I would add in this other part about this additional source of fuel that ketones provide for the brain, because we know that the brain can become insulin resistant even if we're testing the blood and there's no insulin resistance that we can see, the brain can still be very insulin resistant. And they've seen that in research studies. I can't test for it in the clinic, but I know it to be true based on research studies that when they look at schizophrenia, bipolar, major depression, Alzheimer's, they see insulin resistance in the brain, even when the body, we're not seeing it in the blood. And so when we put someone into ketosis, we bypass that blockade, that energy blockade that's going on from central insulin resistance. Essentially, if we don't have an insulin signal, we can't get those glucose molecules into the neurons, but the ketones go right in without an insulin signal. So this is huge. Stabilizes these neural networks, reduces oxidative stress and inflammation, gives mitochondria a steady source of fuel, and then the mitochondria are getting this signal to start proliferating and recycling themselves. These are going to provide ongoing benefits over the longer someone stays in ketosis, the better their brain is going to function. Their brain functions better at month 6 than month 3 and better at month 12 than month 6. It's just incredible to see when people can stay in it long term. So, you know, it's all those mechanisms. And then, in addition, we're getting rid of, a bunch of junk out of their food. We're adding in, making sure that they're nutritionally replete. Um, I think all of it is important. And then, of course, if we can get them exercising and doing some mindfulness practices and getting up in the morning and seeing sunlight and blocking their blue light at night, then we're winning the game. I mean, then, I've seen the most severe chronic conditions get better if we're doing all those things.
Can you describe one of the most, just the index case, the case that maybe not that you were proud of, but like you wish could be replicated again and again? Can you? Well, certainly your kids getting the care they needed.
Yeah,
I'm sure
sure.
you want to see that be replicated again and again, but
Yeah,
maybe
sure.
the cases of reversal really give hope to
Yeah,
people out there. So I'd
yeah,
love to if you could share,
yeah,
something that's hopeful.
sure. Yeah, I'll tell a story of someone who not even that long ago, met 6 months ago. I'll change a couple details to protect their identity, but I'll give all the important points. So, um, young woman, 25, started off with a diagnosis of mania, hospitalized, put on medications, um, ended up on multiple psychiatric medications, eventually had a series of hospitalizations and became essentially chronically psychotic, hearing voices all the time, from the moment waking up until going to bed. This young woman, ended up in residential care, um, essentially meaning couldn't live independently, was living like with, supervised care for 3 years from residential program to residential program, never got back to life. So 25-year-old now, 3 years, basically like institutionalized on huge amounts of medication. So I don't know if people, know some of these medications, but the most powerful antipsychotic medication we have is this one called clozapine. And it's the most effective one, but it also has some of the worst side effects. So this person was on a huge dose of clozapine. Blood levels were through the roof, plus lithium, another atypical antipsychotic at a maximum dose, multiple other medications to manage all the side effects of those medications, um, and was sleeping 15 hours a day because of the sedation effect of these medications. But when awake, was hearing voices the whole time. Um, so that was the state in which I met this person. this young woman. She comes to Accord, our program, and gets put on a ketogenic diet. We started her off on an exercise program. And, she had a history of exercising when she was younger, hadn't done it in 3 years, but was willing to start doing it, willing to eat the food, got into ketosis pretty quickly. This young woman, even despite being on all those weight gaining medications, metabolically didn't look unhealthy on labs, interestingly enough. Had a hemoglobin A1C of like 5.1, a low HOMA IR, like, just was looking and, lipid panel looked fine. But like I said, doesn't mean there's not central brain insulin resistance. So within a couple of weeks, started saying, I'm feeling better. I started lowering medication. Um, month two, voices are way better. Starting to think about making music again, which is what her passion is. Started actually doing that. Now awake more of the day because I'm lowering the medication. Ketone levels are looking great now. Like, sometimes, on the Keto Mojo, getting up to 3, or so. Um, and starting to think about going back home. After a couple months in our program, goes back home and continues on the ketogenic diet. We keep lowering the medication, gets a job now working 25 hours a week at a restaurant, sets up a music studio at home, and is now making music and has a goal to put out a song a week, and is now doing that. We're down to one less than a fifth of like 20% of the dose of clozapine that we started on. So like started at like 450, we're down to below 100 now. Off the other antipsychotic medication, lower dose of lithium, um, exercising regularly, and the biggest change is personality. Like she's smiling and engaging and funny and like a real, genuine fun person to be with and have a conversation with, which was not the case when she first came. I mean, she looked like someone who was drugged and, like what we used to call like sort of on the back wards of a chronic psychiatric hospital, like someone who looked like they were going to be psychotic for the rest of their lives. And now literally almost never hears one of these voices. Like they're almost essentially gone. And it's only been 6 months.
That's amazing. That's amazing. And uh, prior to your experience with metabolic psychiatry, had you ever seen anything like that?
Never, never. You would never. I mean, in fact, if I tell my colleagues about this, they don't believe me. Unless they know me well, right? But like if I just tell some, psychiatrists who I've never met before about this, they won't believe me. They'll say that's impossible. Um,
And it's crazy because it's in the literature, by the way. It's in the case series are in the literature. We
yeah,
have
that's right.
longer case series of 40 patients. We have, uh, we have case reports, certainly. We also have pretty, I'd say pretty convincing data. Certainly, this is a neurologic intervention. I mean,
That's
in
right.
terms of the efficacy that borders a lot of seizure medications, which, by the way, are used for mood
That's
stabilization
right.
all the time. So it strikes me as odd that people don't connect the dots. But do you feel like sometimes it's funny, we've talked about this on the podcast, like Sam Wise, back in 1880, he's like telling everybody, hey, you guys are all doing it wrong. There's this imaginary thing on your hands and
That's
the
right.
instruments you use. You gotta wash them, And he's going and telling the medical societies, and they're like looking at him like he's nuts. And
Yeah.
eventually, they convince him he's nuts, and he gets really secluded, and I think he attempted suicide at one point. Um, so I'm just I'm curious. I'm curious as to if how long it'll take to your colleagues to sort of understand and
Yeah.
think that that's appropriate.
Well,
Um,
I think it's going to take a while. The way I see it changing is, the younger generation, people who are currently right now in medical school or, the early part of psychiatric residency, they've got a window of open-mindedness still, right? They can hear this and say, "Wow, that's really exciting. I want to learn about that. I want to understand the connections between all those mechanisms that have been studied by the neuroscientists for years and how it improves someone with psychosis or bipolar or severe OCD or severe depression." They want to know. But someone who's been in practice for my vintage, 25 years in practice, and they've believe the neurotransmitter thing and they've devoted their whole life to seeing it that way, it's going to be tough to convince those guys and gals. Some of them, yes, we'll convince some, but we're going to get a lot of resistance from the mainstream, unfortunately. Yeah.
Yeah, and can you, because you have this outpatient program, I think you talked about it, but you also have like a residential program, right? Is that
Right.
right? Do you want to just briefly talk about that?
Yeah, so the thing that I was describing where the young woman came to called Accord is a residential program.
Oh, okay.
So
Yeah.
it's outside of Boston in Arlington, Massachusetts. We have a little house. It's a very small program, very individualized. There's a program director who's a social worker and a skilled therapist, and we have a great dietitian who understands ketogenic diets and brain health. We've got an amazing chef. So, we're cooking for people when they come, although we're trying to get them involved as much as possible in the cooking because in order to really use this treatment to the fullest, you have to be able to cook, or someone living with you has to be able to cook for you, because you're never going to be able to get the full benefits of a well-formulated ketogenic diet from takeout or even a meal service. It's just not going to happen. You have to be able to, do it yourself. And so a lot of people don't know how to cook these days. So that was very important to me, not only that we're providing really good quality food that people want to eat, really tasty, but also teaching them how to cook and sustain so that it's sustainable when they get back home. So people come in, they're eating that diet. We've got CGMs on everyone, continuous glucose monitors. We're measuring ketones every day. I'm doing a big lab panel in the beginning and every month, looking for all these rule outs that we talked about. Um, and sometimes using some supplements when needed based on the lab work. Sometimes there's some standard supplements that a lot of people benefit from, of course. We're getting people exercising, so we set them up with a personal trainer. We take people on walks 3 times a day. So after breakfast, after lunch, and after dinner, there's always a walk, trying to get that sunlight and also just that, free glucose disposal from walking and not needing insulin when you're using the muscles. And then we have a, mindfulness, mind body component of the program, which is also very important. We now understand too how much, metabolism is connected to that kind of mental state and how much, through stress and cortisol, you can really, really reverse some of the benefits that you're getting from the diet and the exercise, right? And we see that a lot, actually. It's very interesting. People, they're wearing their CGMs and they're looking at their numbers, and sometimes they'll come up to us and say, "What's going on? My blood sugar is 150. I swear I didn't cheat. I didn't eat anything that I shouldn't have eaten. Why is my blood sugar 150?" Um, and invariably we say, "Well, are you feeling anxious?" "Yeah, I'm totally stressed. I'm panicking." "Well, that's what's shooting your blood sugar up. Let's do a mindfulness exercise." And we can watch their glucose go down, to below 100 in 10 minutes, just from relaxing and, de-stressing and doing a mind-body practice. So we know how powerful that is too in terms of how all this works. And then, so we're creating a fertile ground for people to have motivation, have cognitive improvements, but also to, their brain is now more plastic. It can change. And so often then, whatever thing they were stuck on in their past or in psychotherapy also becomes much easier to work with, once we get people in a good metabolic state.
It's so important, just like holistic care.
Yeah.
How important like holistic care is, and
Yeah.
people want to discount sleep. Don't discount sleep. People want
Ah,
to discount light. Don't discount light. People want to discount exercise. No, exercise is probably the most potent tool, anti-anxiety, anti-depression tool that we have. I think it's more potent than pharmacotherapy.
It is.
And the problem is it's so much more helpful. The side effects are so much better, than some of these medications. So it's truly like a blessing, because you get to improve your body, and the side effect is feeling good.
Yeah. And
And
the
I
other
think,
side effect is living longer and healthier too, which is
yeah,
not so
what
bad
it
either.
sounds like you're doing is just like this is actually helping people
Yeah.
with lifestyle, and you're showing, and I know, I can't wait to see the publications that you guys produce, because I know it's going to be extraordinary. I'm so grateful, that you're doing the work you're doing. We need more people like you. Hopefully you can evangelize some others out there.
I'm trying. Yeah. I mean, I'm trying to get the word out as much as possible, coming on, talking to you, and I do that kind of thing, but also going to conferences where psychiatrists and other therapists are there, and speaking directly to the people who may be resistant to what I'm saying. They may, walk out the door and say that guy's, got a screw loose. I don't care. I'm gonna reach a few of those people in that audience. And that's really important.
So if there's a listener who likes what he's hearing right now, or she is hearing, or they know somebody that could benefit, where should we direct people? There's going to be somebody who
Yeah.
needs good mental health care, somebody who needs,
Yeah.
more than the traditional psychiatry. Where can we send people?
So people can access this program that I'm describing by going to the website. It's Accord, Accord, MH.com. It stands for Accord Mental Health, but it's just accordmh.com. And they can see our program. They can see some of our early outcomes showing the tremendous benefits that we're describing, learn more about how we do it, and also reach out to us if they want to either come to the immersive program, or we do have a health coach who can help people from home too. If people don't have the wherewithal or the time or the resources to come to Massachusetts, we have a health coach that can work with people as well to, you know, implement these changes at home. But what I find is that if possible, starting off in the immersive program really helps, because especially someone who's been through years of mental health treatment, all these changes that I'm describing, that's not easy to make on one's own. No matter how supportive your family and friends may be, that's a lot to do. And it's nice to get immersed and have it shown to you how to do it, and to get in those habits before you go home and try to, fly solo or with a coach, to do all these things.
That's awesome. We'll put that on the show notes. Any parting words of wisdom out there for somebody who's listening to this, and any last bit of advice? And do you eat ketogenic? That's the other question.
I
Do you?
do.
Good. Okay.
I do. I do. Yeah.
Yeah.
I
So
start. I
you
before
promote
I
you
before I
practice
recommended
what you
it to
preach.
anyone, I decided I need to make sure that this is doable, and it's not that, how hard is it? Let me figure it out myself and see what it's like. And I never went back. That was 5 years ago. I've never gone out of ketosis. I mean, I may sometimes, stay in low levels. I'm not always shooting for the highest levels, but I'm always in some amount of ketosis. And I feel 20 years younger than I did 5 years ago. So I mean, I can say for sure this is, you know, personal experience. Like, this is good for any human. You don't have to have a mental health condition, um, for sure. Um, but in terms of like parting message, I mean, I think the most important thing to people who are listening, if you or your family member or someone has been diagnosed with one of these serious mental health conditions, like schizophrenia, schizoaffective disorder, bipolar disorder, severe major depression, and you've been told, or they've been told, you've got a condition that you're going to live with for the rest of your life, you're going to be on these medications for the rest of your life, and the best you're going to be able to do is reduce some of these symptoms and sort of barely function. That's not true. That is not true. And that is what people are being told all the time. um, just accommodate towards it, accept your diagnosis, take these meds, live with it. It's just not true. They don't have to just live with it. You can actually get better. It is possible. And that's the most important message.
Dr. Bernstein, Dr. Matt Bernstein, thank you so much for coming on. I appreciate you. I appreciate your work. It was such a pleasure to meet you in DC, and I look forward to, just following up. We got to do this again. I know Brian's going to be so upset that he missed this, but
Yeah.
I'm glad you were able to come on, and I appreciate you coming on and telling us and educating us about metabolic psychiatry. So thank
Thanks
you
for
very
having
much.
me. Yeah, it was great to be with you. And thanks for having me.